Hello friends, let us now learn about one important disorder which is called as phenylketonuria. There is something called as phenylketonuria. This phenylketonuria, there is one liner. This is the most common metabolic disorder of amino acids. Most common metabolic disorder of amino acids is phenylketonuria. So, what is the cause of phenylketonuria? Right, phenylketonuria can be divided into two types. We have classical phenylketonuria, whereas we have non-classical phenylketonuria. So first, classical phenylketonuria occurs due to the deficiency of the enzyme phenylalanine hydroxylase. Deficiency of the enzyme phenylalanine hydroxylase causes classical phenylketonuria. Then we also have non-classical phenylketonuria. Non-classical phenylketonuria occurs due to the deficiency of enzyme dihydroxybiopterin reductase. If this dihydroxybiopterin reductase is deficient, then we have non-classical phenylketonuria. Similarly, if this GTP cyclohydroxylase is deficient, this hydroxylase, if GTP cyclohydroxylase is deficient, even then it results in non-classical phenylketonuria. There is one more name for this GTP cyclohydroxylase deficiency. This is also called as Sigawa syndrome, or we have hereditary progressive dystonia. This is also called hereditary progressive dystonia. So we have different names for GTP cyclohydroxylase deficiency, that is non-classical phenylketonuria. Then we have Sigawa syndrome and hereditary progressive dystonia. Right? Next. So what happens in phenylketonuria? In phenylketonuria, due to the deficiency of phenylalanine hydroxylase, if we are talking about phenylketonuria, then that means we are mainly referring to classical phenylketonuria. So in classical phenylketonuria, there is a deficiency of this enzyme phenylalanine hydroxylase. Because of the deficiency of the enzyme phenylalanine hydroxylase, the conversion of phenylalanine to tyrosine is blocked. Because the conversion of phenylalanine to tyrosine is blocked, this phenylalanine accumulates and it increases, whereas this tyrosine deficiency occurs. Right. Now the clinical features are just based on increase in phenylalanine levels and based on decrease in tyrosine levels. When there is increase in phenylalanine levels, this phenylalanine will accumulate in the body and it gets converted to phenyl pyruvate. It gets converted to phenyl pyruvate. Okay, I'll write it here. Okay. Yeah, right. This phenylalanine, due to increased phenylalanine, it gets converted to phenyl pyruvate. Okay, it forms phenyl lactate and it also forms phenyl acetate. Okay, this among all these, if you see, this phenyl acetate is mainly responsible for mousy odor. Mousy musty body odor which you see in phenylketonuria is due to this phenyl acetate. And because of the accumulation of phenylalanine, especially when this phenylalanine gets accumulated in the brain, it leads to mental retardation. mental retardation is the side effect due to accumulation of phenylalanine in the brain. Then there will be other side effects like mental retardation, and there will be microcephaly also is seen due to increased phenylalanine in our brain. Then that is one thing. Second, then there is tyrosine deficiency. This tyrosine deficiency, this tyrosine leads to formation of some important products. So we will see. Tyrosine, by the pathway, it forms melanin, that is eumelanin and pheomelanin. That means the color of our body and eyes, hair color is due to melanin, which is formed from tyrosine. But here, due to the deficiency of tyrosine, this tyrosine is now deficient. So this melanin is not formed at all. Now because the melanin is not formed, there will be deficiency. This decreased tyrosine results in deficiency of melanin. Remember, if there is melanin deficiency, the patient suffers from hypopigmentation disorders. That means the patient has blue iris, there can be fair skin and blonde hair. The patient has blue iris, fair skin and blonde hair due to absence of melanin or hypopigmentation. Then very good, fine. Then what are the other features that occur from what are the other important compounds that are produced from tyrosine? Tyrosine is also important for the synthesis of the catecholamines like dopamine, norepinephrine, epinephrine, and it is also important for the production of thyroid hormones. Now, because of tyrosine deficiency, all this catecholamine synthesis is blocked, and even this T3 and T4 synthesis is also absent due to tyrosine deficiency. Now, what are the problems due to this? Simple. Due to this, the tyrosine deficiency will result in decreased catecholamines, which will cause irritability symptoms will be there due to decreased catecholamines, and this tyrosine deficiency also leads to deficiency of T3 and T4, which will lead to hypothyroidism. So you see features of hypothyroidism like mental retardation, irritability, intellectual disability, enamel hypoplasia and irritability. All these are seen due to tyrosine deficiency. So it's very simple. Phenylalanine accumulation results in mental retardation, microcephaly, growth retardation and mousy odor. Whereas the tyrosine deficiency leads to hypopigmentation of skin, hair and eyes, resulting in blue iris, fair skin and blonde hair. And tyrosine deficiency also causes catecholamine deficiency, resulting in irritability. Tyrosine deficiency also causes thyroid hormone deficiency, resulting in hypothyroidism. The features of hypothyroidism like mental retardation, intellectual disability, enamel hypoplasia and irritability are manifested in a patient suffering from phenyl ketonuria. So these are all the clinical features of phenylketonuria. So now let us learn about the diagnosis of phenylketonuria. Now, how are we going to diagnose a patient with phenylketonuria? So we have some tests. We can do ferric chloride test to urine with urine. So if you add ferric chloride to urine, this ferric chloride, due to the presence of phenyl pyruvate in the urine, this ferric chloride gives green color. So that is ferric chloride test. In ferric chloride test, due to the presence of phenylalanine, this ferric chloride gives green color. Then we have something called as Guthrie's test. This Guthrie's test is done through the blood. It is a blood test which is done in newborn, and in this Guthrie's test we detect presence of increased phenylalanine in the blood of newborn, and this increased phenylalanine is detected to be due to phenylketonuria if it has the levels of more than 1000 micromole per liter. If phenylalanine levels are more than 1000 micromole per liter, then we can call it to be phenyl due to phenylketonuria. It's okay even if you don't remember this value. Then we have tandem mass spectrometry can be done for detection of phenylalanine through the blood. And there are some molecular biology techniques are also available for this detection of phenylketonuria. And we have dinitrophenylalanine test. If you do, phenyl hydroxylase test. If you do this dinitrophenyl hydroxylase test, it shows positive. Okay, so most commonly we use Guthrie's test in newborn to detect phenylalanine or increased phenylalanine levels. Now once you have detected the phenylalanine levels, how are you going to treat the patient? Treatment is first and foremost, you should restrict the phenylalanine in the diet. So phenylalanine is restricted in the diet. There is an artificial sweetener which is called as aspartame. This aspartame is an artificial sweetener and it is contraindicated in these patients because this aspartame is a dipeptide containing aspartate, that is a derivative of aspartic acid, and phenylalanine. So this aspartame, which is an artificial sweetener, it contains aspartate and phenylalanine. So we have to avoid phenylalanine. So this aspartame is contraindicated in these patients. And if phenylalanine is contraindicated, if you see, many of the symptoms are due to this tyrosine deficiency. So you should give this tyrosine supplementation to the patients. Then we also have something called as sapropterin dihydrochloride. Sapropterin dihydrochloride. This is also called as Kuvan. This sapropterin dihydrochloride is a synthetic form of tetrahydrobiopterin. And this, if you see here, tetrahydrobiopterin acts as a cofactor for this phenylalanine to tyrosine conversion. But because, so if we give sapropterin dihydrochloride, then this can increase the activity of phenylalanine hydroxylase. Fine. Now the main issue is, in the beginning, in the starting of the class, I have told you that we have two types of phenylketonuria. That is classical phenylketonuria due to the deficiency of the enzyme phenylalanine hydroxylase, and we have non-classical phenylketonuria due to the deficiency of the enzyme dihydrobiopterin reductase or GTP cyclohydroxylase. Now, how are we going to differentiate it? We have a test. I'm just telling this because one liner has been asked in one of the previous examination. That is, we have tetrahydrobiopterin load test. We do not need to go into the details of this test, but this tetrahydrobiopterin load test actually distinguishes classical phenylketonuria from non-classical phenylketonuria, because the name itself is simple. So here we are giving tetrahydrobiopterin to the patients. If tetrahydrobiopterin is given from externally to the patient, then this pathway is not necessary, right? We are giving tetrahydrobiopterin, and if it is non-classical phenylketonuria, think that the patient has non-classical phenylketonuria and you have given tetrahydrobiopterin. So because the non-classical phenylketonuria, there is deficiency of dihydrobiopterin reductase. But now we have given the product of this reaction, tetrahydrobiopterin, from externally, from outside. So phenylalanine hydroxylase is present in the patient, so the problem will be resolved. But if it is due to classical phenylketonuria, the problem is in phenylalanine hydroxylase, whereas tetrahydrobiopterin is already present in the patient, so the problem does not resolve. This is how we do the tetrahydrobiopterin, and the concept behind the using tetrahydrobiopterin for differentiating classical phenylketonuria and non-classical phenylketonuria. This topic is very important as many questions have been asked from this topic. So thank you guys for watching my lecture. Thank you.